Dr. Holds to set this up. On a side note about Ritalin, I do use it. I do use very low doses of Ritalin for people that have apraxia of eyelid opening. So if they have trouble actually, not the blinking, but the actual opening of your eyelids, maybe something to think about. Very low doses I've found to not impact the cardiac disease, and I do get clearance from primary care physicians, and I've had a good result with it, so it may be something to think about. We're going to talk about neurotoxins and all the different types of neurotoxins. I have no relevant financial disclosures, but I am a primary investigator in several clinical trials that WashU takes all the money for, but I still have to list. Okay, so what do all these products have in common? You heard Dr. Holds during his last talk about Botox, and really it's very similar to Kleenex. We don't go grab a tissue, we grab Kleenex. We don't go grab a cotton-tipped applicator, we go grab a Q-tip. Botox has become that term, and so when people use Botox, we have to think about the fact that that's actually a brand name for a specific medication versus all the other botulinum toxins that are in the same family. And, you know, when we see new patients that have any form of facial spasming syndrome, and we talk about using Botox, the first thing they think of is you know, some of the people that are in the media that can't move their face and have had fillers and Botox and different kinds of things. And the reality is that that's not what we're using it for in patients that have spasming syndrome. We're going to start off with a brief history, some of the pharmacology. We're going to talk about some of the different types of botulinum toxins, why we use them for blepharospasm, what the different brands of botulinum toxin are, and then some adjuvant therapies. So Clostridium botulinum is a bacteria. It's a gram-positive rod. Okay, so it's an anaerobe. It lives in the soil. It's a spore former, so it forms spores, meaning it can go through winters and heat, and it forms a spore that protects itself, and then you get exposed to it in some way, and then you can get botulism. Okay, and botulism causes muscle paralysis, and that's what people died of many decades ago. Again, it's muscle paralysis and causes people to stop breathing. Interestingly, this bacteria produces 7 different types of neurotoxin. It can produce A through, and it's labeled A through G. And what they discovered in the 80s was that this toxin can be used as a muscle relaxant, as a very localized muscle relaxant, so that you're getting the effect of muscle relaxation, but you're not getting the systemic effect of botulism. In medical therapy, types A and one type of B are the most commonly used. Types C and D do not work in humans, interestingly. So in the 1920s is when the first botulinum toxin A was purified. And then in the 1950s, it's when it was discovered that it reduced muscle activity, so it reduced muscle contraction. Dr. Alan Scott, who was an ophthalmologist, was the first person to actually use localized botulinum toxin, and he used it in monkeys to help realign their eyes. So he was trying to inject it into the muscles of monkeys to see what it does to the muscles and what it does to the alignment of their eyes. And then in the late 1970s, he formed Oculinum. Then in 1988, Oculinum was bought very smartly by Allergan and renamed to Botox, and that's where this whole Kleenex and Q-tip phenomenon started, was in the 1980s. In 1989, it was first approved for blepharospasm. It was also approved for strabismus, or misalignment of the eye, and approved for hemifacial spasm, which is another form of facial spasming syndromes. And the 1990s is when it got its first use in cosmetics, because people noticed, and Dr. Jean Carruthers, who's a Vancouver-based dermatologist, she noticed that people that got this injected around their face, they didn't have wrinkles, so the muscles weren't moving, so it didn't move the skin, so they didn't have wrinkles, and that's when it first started getting used for cosmetics and was first approved for the treatment of what they termed at the time the 11s, was the tagline. So the people, the lines between your forehead, the glabellar lines. Botulinum toxin, the way that it works is it prevents the release of acetylcholine. So your nerves go onto the muscle fibers. Those nerves release a neurotransmitter called acetylcholine. The bottom line is that botulinum toxin prevents the release of acetylcholine. Again, types A and B are used in medical practice. Every one of the types has two subunits, has a heavy chain subunit and a light chain subunit. The heavy chain subunit, when it gets injected, it helps it bind to the nerve, and the light chain subunit allows it to get the nerve to absorb the botulinum toxin. And once the botulinum toxin is absorbed, those neurotransmitters, that acetylcholine, cannot get released, which then doesn't allow the stimulation of the muscles. And the different subtypes are different based off of where exactly in the neuron they work. This is probably more basic science than you guys want, but botulinum type A cleaves the SNAP25 protein and has a higher potency, and there's several different brands, and we'll talk about several of them. Type B cleaves synaptobrevin and has a shorter duration. Actually, the only one that's available there is a drug called Myoblock, and we'll talk about that soon. So when the drug is injected, the heavy and the light chain subunits of the protein they attach they bind to the nerve. The nerve then internalizes the protein. That protein then blocks that acetylcholine from being released, and then eventually there's some evidence of nerve sprouting that happens. Now there is a restoration, so this is a drug, whenever I talk to people about botulinum toxin, I say the good and the bad of it is that it goes away. It's good in the sense that if you don't like it, it goes away, or we need to modify the dose, it goes away. It's bad in the sense that if you like it and it works really well, you got to keep getting it injected. And so why do we have to keep getting it injected? It's partly due to the nerve sprouting, but also partly due to reinnervation of those muscles in that area. You maybe, when you've gone into the clinics, you maybe have seen people mixing the Botox. And when we mix it, in most of our practices, we mix it with bacteriostatic saline or some form of a sterile liquid. And the different botulinum toxins are packaged differently. Some of them require refrigeration, some of them don't. But the bottom line is all of them you have to reconstitute. So you have to take fluid, you have to put it into the vial, you have to allow it to absorb the protein, and then you withdraw the fluid, and that's what's ready for injection. And they talk about the different ways of handling this because the idea is to create the least amount of bubbles inside of that vial. You don't want to just shake it like you're mixing a martini. You want to swirl it so that there's least amount of bubbles, because the bubbles then attract that protein and can stick on top of that bubble, and your concentration is less. And theoretically, the concentration, well, you'll hear more about this later, but the concentration can be made into whatever the doctor prefers, and it can be a certain number of units per aliquot of fluid, and it's based off how much fluid you put in there. If you know you've got a vial of 100 units and you put 5 cc's in there, it's a lot different than putting 2 milliliters of fluid in there, so that the concentration can vary. But again, it's injected just under the skin, especially in the upper face, because in the upper face, the layers of you guys heard earlier with the anatomy, there's no real subcutaneous layer. So there's the skin, and then right under that is that muscle. And so the injections for around the eye or in the upper face are right into that muscle layer, which is right under the skin. Many of us use some form of topical anesthetic, and then we do very precise injections. And for especially the oculoplastics people I can speak for, when we do these injections, we're very close to your eye. And because the closer you get to the eye, the more effect the drug actually has. We give a slow administration. This right here is Dr. Hold's getting it. We use a small bore needle and then put direct pressure on afterwards. And you guys learned about the different muscles earlier, but again, in our injection techniques, the injections are very close to the eye so that we can get the most amount of effect with the least amount of drug. We don't give it to patients that are pregnant or nursing. We don't give it to patients with certain neurological conditions. And then try not to give it within 30 days of each other. And when you look at all comers of botulinum toxins, they can have some complications. They can have redness, bruising, swelling. You can have changes in the eyelid, whether it be droopy or flop away from the eye. We call that ectropion or entropion. Dr. Mamari will talk about that later. You can also have things like double vision if it gets into the socket and affects the muscles that move the eye. You can have some allergies. I really have not had a significant number of allergies, but I have had patients that have described kind of a flu-like syndrome for a day, fatigue after the injections. And then this is a guy with a droopy eyelid afterwards. This is a cosmetic patient, so it's quite a bit different. These are injections for the eye, but you can see the eyebrows raised. And here's another cosmetic patient that has glabellar lines that go away. Brands of botulinum toxins. So botulinum toxin A is the most common one that we use. And by far and away, at least in my practice and many of our practices, Botox is the most common. Other ones include things like Dysport, Xeomin, Jeuveau, and Daxi. And we're going to talk about the last two later, but they're actually not approved. Or some of these are only approved for certain indications. Botulinum toxin subtype B is myoblock. It's a much less potent version of botulinum toxin. I personally have never used it, but it is one that is injected at higher doses in order to get the same effect. And just looking at some of these, the main ones that we use for blepharospasm, Botox, Dysport, or facial spasming, Botox, Dysport, Xeomin, and myoblock. These medications are very similar sizes except for Xeomin, which is a much smaller molecule, and they have different indications. But Botox, like I said, is the most common. It has also the most number of indications. It can be used for facial nerve spasm or blepharospasm. It can be used for excessive sweating in your hands and your feet and in your armpits. It can be used for double vision. Chronic migraines is another reason people use it. It can be used in the bladder for people that have spastic bladder. And then cosmetically, it can be used for forehead, glabellar, and crow's feet. And again, this is one of the ones that has to be refrigerated or both before and after reconstitution. And so many of us that stock this super expensive medication in our practice have special monitors on our fridge because if it goes out, it's a big deal. Dysport is another botulinum toxin A. It is not approved for the use in blepharospasm. The funny thing about Botox is that most of us that inject botulinum toxins think about, okay, we know what 1 unit of Botox does, approximately, in the average patient. So a lot of these medications are comparing 1 unit of Botox to 1 unit or however many units, like what are the equivalent numbers here? And this is a medication that's mostly used in aesthetics, but it's used for glabellar lines and cervical dystonia. It's a much larger unit vial, and one of the problems with it is that it's somewhere between 2.5 to 4 units per 1 unit of Botox. So you're injecting, larger amounts. Xeomin is one we use, and I use this pretty commonly. This is botulinum toxin A. It's FDA approved for facial spasms, blepharospasm, cervical dystonia, and then in cosmetics. And one of the benefits to it is it comes in 50 unit vials and it comes in 100 unit vials and does not need to be refrigerated. So it can be stored in a regular cabinet. And the other benefit to it is that it's 1-to-1 unit with Botox. So in my practice, some insurance companies have started requiring Xeomin for patients with any facial spasming, or in patients that have had a less than desirable effect with Botox, I'll actually switch them to Xeomin. Now, the next one is Jeuveau. They kind of went by the moniker online as Nutox. This is a strictly cosmetic product. This is a cosmetic product that's only approved for those glabellar lines. One of the benefits, especially in Medi-Spas, is that it's cheaper than Botox and may have some benefits as far as how quickly it onsets. And the newest one on the market is Daxi, or Daxi-botulinum toxin A. This is a long-lasting Botox, or that's how it was marketed and that's how it was studied. So most botulinum toxins, you usually get about 90 days or up to 3 or 4 months of effect. The idea of this was that this had a quicker onset and had a longer lasting effect, probably closer to 5 or 6 months, so that potentially patients, especially aesthetic patients, wouldn't have to come in as often. Now currently it's approved for aesthetics and actually just recently got an indication for dystonia. And the reason that it works the way that it works is because it has an extra positively charged protein that then allows it to bind and stick better in the cells. And interestingly, some of my colleagues, I have not used it, I think you have, right, Holtz? And my colleagues that have used it have described that it's actually more uncomfortable of an injection. It has more burning with the injection. And it has to do with that pH imbalance within the molecule itself. Myoblock, botulinum toxin B, it's the only botulinum toxin B. This is an FDA approved for cervical dystonia, and it again, coming down to a 1-to-1 ratio, this is 10-to-1 for Botox. And so personally, I've not used this medication. I don't know many people that do. I think a couple things that are potentially down the pipeline. There have been a few studies looking at topical botulinum toxin A, and it's been relatively not been effective or as effective as it likes, because the skin surface, your skin surface, has a pretty good barrier to it, and these proteins have a hard time getting across the barrier. But Allergan is definitely working. They spent $90 million to try to see what they can do with this. Botulinum toxin, all botulinum toxins are a zinc-based protein. This is and this zinc metalloproteinase or protease enzyme, if you are able to locally increase the amount of zinc in the area, the Botox probably has some benefit and has some better longevity for the medication. Now, if you just take zinc over the counter, which you can buy at your stores, most of it does not get absorbed in your gut because your gut is not set up to absorb zinc. But if you add certain chemicals called phytates or phytase, this will allow better absorption within the system. And Dr. Sopaker came out with a medication years ago called Zytase, which is a combination of zinc and phytase. It's available on Amazon. It's awful expensive, especially when you consider that you could buy a truckload of zinc for the same price as one box of Zytase. But it includes phytase with it, which helps to break down phytate, which allows for better absorption of the botulinum or of the zinc, which then theoretically has increased efficacy of that Botox or botulinum toxin. So, in conclusion, botulinum toxins are purified bacterial proteins. So this is a naturally based chemical, and it causes localized paralysis. That's the idea. It's I describe it as a muscle relaxant. It's a local muscle relaxant. The main ones that we use in the setting of facial movement is, well, the main two are Botox and Zeman. And if you increase your dietary zinc, it may allow for somewhat better absorption. So, sorry I was late. I was coaching my daughter's volleyball game. So, thank you guys very much. And I'm happy to answer any questions too. Yes?
So, this might be a myth, obviously, from what you said. I was under the understanding that you couldn't use a topical kind of anesthetic or just anesthesia before a Botox injection because it would have a negative effect on the effectiveness of that Botox.
I don't think that's true. I think the majority of us use some form of a topical anesthetic.
Not go there.
I'll be honest with you. I don't think I actually don't think, I think that the topical anesthesia, so there was a time when that was definitely a thought.
Okay.
But I'll be honest with you, I don't think that the topical anesthesia does that much either. So I think it helps. I think there's some of the shots that you still feel, and some of them you may not feel as much, but there's plenty of patients that don't use it. Oh, sorry, I should have, she said topical anesthesia, does it reduce the efficacy of the botulinum toxin?
There was a paper that suggested that about 25 years ago. There was a paper that suggested that 25 years ago, and I don't think anything has ever backed it up. But
I've never been offered it, so I thought that was why.
Well, you also have to understand there is some regulatory issues with using topical anesthesia. So I use some on you, and I use some on you, and I use some on you. Well, how do we know that the vial wasn't contaminated? And and there's some practices and some of my colleagues that will actually prescribe the patient it, and they get to bring their own in. That's another way to do that.
I'm from Canada, so I'm sure this is only related to me, but are all these different kinds of botulinum toxins available in Canada, or are they all approved?
I don't know the answer to that. I'm sorry. I can help look it up for you, though. Yeah.
So just a question about Ritalin.
Yeah.
Hold on.
Here's a question about Ritalin for apraxia.
Did you find that Ritalin lasted? How long did it last?
So when I started at 5 milligrams once daily, and I have them take it in the morning because, as you know, Ritalin is a stimulant medication, and it does stimulate the basal ganglia, which is one of the issues that is affected with blepharospasm. And when I use it, I start 5 milligrams once in the morning, and I've got patients that have taken it up to 5 milligrams twice a day. I don't have anybody on the long-acting Ritalin, and I have gotten calls from pharmacists because I'm an eye doctor and prescribing a ADHD medication. But that being said, it's a very low dose with, in my hands, relatively low side effects. Ladies first. Yeah, Phytase. Yeah, Zytase.
Just a question on, would that be something you would take only around a week before you have
It's 5 days of pills, and you're supposed to take it 4 days before your injection, and then 1 day after.
Thank you.
Mm-hmm. And it's like $60, so it's pretty expensive, to be honest.
Did they win?
They lost their first game. We were undefeated. Dang it. It was a close one, though.
Dr. Couch, just clarification, I think my blood is 40 to 50 units to 1 unit of Botox, not 10.
Okay.
Yeah, just want to make sure that I
Yeah, fair enough.
use it for surgery and lots of other things, so that's the conversion I use.
Okay, very good, thanks.
Charlene, while you're there, Dr. Hyde, have you found it to be a good drug for your dystonia patients? If you can let her comment. I used it many years ago, and I found the duration and effect to be disappointing.
Oh, so I can use this.
But my botulinum B, have you found it to really be effective for many patients?
So no, the specific. So for Syria, I use it. Some of the patients I've used it, but since more botulinum toxin came to market, I've not used it.
Yeah.
Okay. So I agree that A is probably the best for dystonia.
I just commented on my journey through blepharospasm. I've been treated with Botox just for zeroing also had myoblock. And yes, myoblock, the ratio is about 40 to 50 to 1.
Okay.
But myoblock comes on very quickly, it disappears really quickly, so it doesn't last long. And the side effects, things like dry mouth and so on, are things that have to be handled. So not pleasant.
What was your experience with Xeomin versus Botox? Because we wrote Dr. Holtz and I wrote
I
a paper.
simply can't tell the difference. I've switched between them because that's what they had that day when I turned up.
So Dr. Holtz and I wrote a paper on that, and the patient experience was that the onset's quicker, but it doesn't last quite as long.
Which does?
Xeomin.
Sorry?
Xeomin.
Oh, I find it does work.
Yeah. Cool. And I think that's the variability, right?
Does Botox ever cause eye vision problems?
If it causes vision troubles, it's usually because it impairs the blink. Your eyelids function as a windshield wiper blade. She asked, does Botox ever cause vision troubles? You know, your eyelids function as a windshield wiper blade over the top of your eye. And if you have impaired blink or incomplete closure and you have dryness or some irregularity in the surface of your eye, then it blurs the vision. That's probably the most common reason for it. Yes?
So Daxxify just approved for cervical dystonia, just approved. So we don't know yet, they haven't hit their 6-month mark for the general population. Let's assume they do, and let's assume all the feedback is this is great. How does it get approved for blepharospasm?
So there have to be trials for it. And so they have to seek that FDA approval indication, and that's a whole, that requires, and that's back to my disclosures, those are the trials we're doing for different drugs for different diseases, but it requires trials. And then you have to submit the data to the, and it requires a fair amount of legwork and a fair amount of capital investment from the companies to be able to seek FDA approval for specific indications. Then the next step after that is to get the insurance okay with you using something different than Botox or Xeomin.
Okay, so it's really up to the Daxxify company will really be the one taking the charge.
Yep. It's if they want to enter that market.
I've encouraged readings to study that. Jubot, I think, is also looking at cervical dystonia indication, surprisingly, and I've encouraged them also. And I think Dr. Gervasio is going to have a couple of comments on this, but it's sort of hard. It was hard for me to find a difference initially between the botulinum A's, and what I'm starting to discover is the sort of spread, focal spread, how much it spreads from an individual point is significantly different. We all knew that Dysport had much greater spread a long time ago, but actually all the other drugs had variation, in my opinion.
Dysport for sure has the widest diffusion. Yes?
I just missed that last one. What's got the widest?
Dysport.
Well, I think we've come almost perfectly to noon. Let's give a big hand for Dr. Cooper.